Prostate cancer is one of the main reasons for death in civilized countries. In fact, for 60-year-old men, the probability of getting prostate cancer in their next 10 years is around 7%. It seems that incidence is not fully correlated with mortality. The number of new cases detected in civilized countries, especially in North America and Australia, is growing dramatically. This is probably due to PSA screening that has a greater effect on the incidence of the disease than over its mortality rate. How does PSA testing actually work? PSA is the acronym of prostate-specific antigen. It is a serine protease synthesized by the prostatic gland that hydrolyzes proteins from seminal coagulum when it passes by the prostate. This allows liquefaction and expulsion of semen across the urethra. What does it happen when we analyze a serum sample? PSA is there in small concentration. The point is that this concentration is higher when a patient suffers prostate cancer. This is why this has been used so far to detect the pathology. However, this PSA increase is not just due to the presence of prostate cancer. It can also be caused by a benign prostatic hyperplasia or by a prostatitis, leading to wrong diagnosis. Perhaps we could use epigenetics. Epigenetics is the study of changes in gene expression that occurs without a change in the DNA sequence and are heritable. There are different epigenetics mechanisms, like DNA methylation in CpG island or like covalent post-translational histone modification. This will be the one we will use. There are modifying enzymes that can add or remove specific modifications, like methylation or acetylation, in specific amino acids of histone and terminal. These enzymes are altered in case of cancer, and this fact generates the deregulation of gene expression. The chip-on-chip technique allows mapping of histone modifications. The first chip is the acronym for chromatin immunoprecipitation. The second chip is a tissue microarray that we use to sequence the isolated DNA. The above allows us to use the histone modification on the prognosis, diagnosis and therapy of prostate cancer. Let's talk about the prognosis. After a primary tumor extraction, cancer patients have up to 50% chances for the appearance of a new tumor. Nowadays, tumor characterization is based on a grade and stage scale. This scale parameters groups patients with similar clinical histological features, however with very different clinical outcomes. Histone modifications can improve the situation, because they allow calculating a risk prediction of biochemical recurrence when grouping patients. What does it mean? This means that we are going to obtain more accurate and cohesive clinical outcomes, and this will improve the therapy. We can also use histone modification for the diagnosis of prostate cancer. We can distinguish between a prostate cancer and a benign prostatic hyperplasia by detecting two specific and different indications. Histone modifications patterns are altered in case of cancer. Then, when the percentage of cells expressing these histone modifications is low, we will diagnose prostate cancer. But if this percentage is high, we will diagnose a benign prostatic hyperplasia. We can also use histone modification in the therapy of prostate cancer. In the case of a person who has a low level of acetylation, we can increase that level by using an HDAC inhibitor. This way, over time our patient is going to recover his optimum modification level, and therefore improve his pathological state. In summary, we can say that histone covalent modifications can be used in prognosis to predict the right risk of recurrence, in diagnosis to distinguish patients with hyperplasia, in therapy to restore the altered modification pattern.